Hello, my name is Dr. Stephen Thomas, and what we've done is to produce 3 lectures on basic dermatology aimed mainly at medical students or junior doctors, and through these we will take you through the description of skin lesions and rashes and also through common skin conditions you'll see in clinical practice. First of all, for describing skin lesions, there is the macule, which is basically a flat spot or patch of different coloured skin, such as a freckle. There is a papule, which is a raised spot on the surface of the skin, generally less than 5 millimeters in diameter. There is a nodule, which, similar to a papule, is a raised area of skin, but is generally thought of as being greater than 5 millimeters in diameter. A plaque is a uniformly thickened area of skin, such as in here we've got very typical plaque-like psoriasis, which here has a well-defined edge. Scale, which is the flaking of the stratum corneum. Crust, which is usually refers to dried exudate on the skin surface. Pustule. Now, a pustule is a skin bleb filled with pus. A cyst, which is a deeply situated fluid-filled cavity, which often does have a lining, such as in a sebaceous cyst, but doesn't have to, such as in an inflammatory cyst of acne. A vesicle, similar to a pustule, is a small bleb of skin, but in this case is filled usually with clear fluid. So basically a vesicle can be thought of as a small blister. A fissure is a crack in the skin, usually where the skin is thickened, such as on the heel of the foot or on the hand. Erosion is partial loss of the epithelium of skin or mucous membrane. An ulcer, which is the total loss of epithelium of the skin or mucous membrane. And lichenification is thickened, rough skin, usually due to an underlying inflammatory process, giving it this leathery appearance and often made worse by scratching of the area, which causes a reactive thickening. We will now go on to cover some common dermatological conditions. Here, beneath the breasts, we have a red macular area. The tissue here is moist and rubs due to friction, and in this case, it is due to Candidiasis, otherwise known as thrush. Candidiasis is a yeast caused by Candida albicans. It's an opportunistic pathogen, and when someone presents with thrush, we need to look at conditions which may have caused a decrease in systemic immunity or local immunity, things like diabetes, poor hygiene, pregnancy, use of antibiotics, particularly broad-spectrum antibiotics, corticosteroids, either orally or topically, and HIV. Sites, major flexures, plus also on the tongue and mouth, genitals, and can also affect the nails. The diagnosis can be assisted through taking swabs of mucous membranes, taking scrapings of skin, but generally it is a clinical diagnosis. Treatment is topically with imidazoles such as clotrimazole. A topical steroid may be added to reduce the inflammation. In the mouth, nystatin drops or a miconazole gel can be useful. And in vaginal thrush, clotrimazole comes as a vaginal cream or as pessaries. Here we have a erythematous annular rash, with central clearing. On asking the patient the history of this, they may say that this has slowly expanded over the previous 2 to 3 months and is quite itchy. And this is a dermatophyte infection, which is a fungal infection as opposed to a yeast infection in thrush. The dermatophyte fungi invade the stratum corneum of the skin, as well as hair and nail. It's a very common condition, and some fungi infect humans only, others can infect both humans and animals. Clinically, the area is itchy and red, slightly raised, annular rash with central clearing, which is where the body's immune system is eradicating the dermatophyte. And it'll slowly grow in size. There may be surrounding satellite lesions. Here we have some tinea of the groin, a major flexure, and showing some satellite lesions. And yes, this area would be incredibly itchy. Often this is treated with a topical imidazole, a topical antifungal, with a low-dose cortisone cream. In the skin flexure, you don't want to use too potent cortisone creams because with the occlusion and the moisture, they may cause damage to the skin. In the scalp, you can have patches which are dry, scaly, itchy, and hair loss, or you may actually develop a carry-on. This is seen particularly in children and may be due to zoophilic dermatophytes, dermatophytes from animals, which can be more aggressive in humans, and it produces this large boggy area which invariably needs oral antifungal agents. Here the nails are infected with a dermatophyte and they have become thick, white and chalky with some onycholysis or separation of the nail from the underlying nail bed. The diagnosis, again, it's usually clinical but may be assisted by doing skin scrapings or nail scrapings. And with the nail scraping, you want to scrape the white, friable material from under the nail into a sterile jar. Treatments, as we said, were, again, firstly, you may look at the imidazoles, such as Canesten cream or Lamisil. These creams may be applied once or twice daily for 4 to 6 weeks. Generally, you apply the cream once or twice daily until the rash subsides, and then for another couple of weeks afterwards to make sure that any residual spores are also treated. In terms of the carry-on, or if the fungal infection is widespread, we may look at using a oral antifungal such as griseofulvin, which needs to be taken with a fatty meal to assist absorption. Griseofulvin is very effective. We just need to keep in mind that men who take griseofulvin should not bear children for 6 months after stopping the medication due to the effects it can have on sperm. Nail infections or with dermatophytes or onychomycosis can be very resistant to treatment. Generally, we start initially with a topical lacquer such as Locerol, applied once or twice per week for 3 to 6 months. And if this doesn't work, then Lamisil tablets can be very effective, which are prescribed for 2 weeks to 6 months. Here we have a young lady with an erythematous macular area on her lower leg. On questioning, the history is that this developed over the past 2 to 3 days. It is warm and tender, and there is no sign of injury. The patient is a little unwell with some low-grade temperature. Close examination of the skin shows a orange peel-like development where the skin is inflamed but is being tethered down by the appendages of the skin, giving it this orange peel appearance. And this is cellulitis. Cellulitis is an infection of the subcutaneous tissues with usually a staph or strep aureus infection. The area of cellulitis is spreading, tender, and there may be some associated lymphangitis or lymphadenopathy. As we said, usually it is Strep pyogenes or Staph aureus causing the infection, but not always. And then erysipelas is a superficial form, classically involving the face, usually due to Strep pyogenes, and not seen a lot in clinical practice these days. So cellulitis, you look for a potential entry point, which is not always present. A swab can be useful to see if the antibiotic used is the appropriate one, particularly if the person is not improving. And then various antibiotic regimes, things like cefalexin, 500 milligrams, QAD, orally for 7 to 10 days. You can also use dicloxacillin, flucloxacillin, clindamycin, and if severe, will need hospital admission for parenteral antibiotics. Here we have a 4-year-old girl who's come home from school, and if you look carefully, you can see little white areas attached to the hairs. These are actually nits, and nits is an egg attached to the hair shaft, and these are laid by lice, this lice being about 2 to 3 millimeters in length. Head lice, it's a parasitic infection. The parasite lives on human hair and feeds on the host's blood supply. Very common, with a prevalence at about 10% in children, and usually there is scalp-to-scalp transmission in primary school-aged children. As we said, the adult louse is about 3 to 4 millimeters long, and the vast majority of what you're seeing here is not the louse but the nits, which are laid by the louse. Treatment: wet combing with a fine nit comb and hair conditioner daily for 10 to 14 days has a low success rate of about 40%. Generally, it is advisable to get an over-the-counter preparation such as Quelada, which is permethrin, wash the hair, leave it in for 20 minutes to kill the lice, and then rinse, and repeat the process in 7 to 10 days' time to make sure that you kill any lice that have hatched in the interim. Also, wet comb out the nits and lice regularly. There can sometimes be a significant volume of nits and lice that you do need to remove with the lice comb. Close contacts should be examined and treated if necessary, and the school should be informed, though exclusion is not necessary. Pillowcases, combs, brushes should be washed in hot water at about 60 degrees Celsius, and that can usually kill the lice and nits in those areas. Here we have a young lady who has presented with vesicles or small blisters on her right hand with a erythematous or surrounding red base. Things that can cause this include a contact dermatitis, an irritant dermatitis, say coming into contact with a toxic plant or caterpillar. In this case, there's no history of that, but there was a history of blistering crusting lesions on the lips, and this is herpes simplex. When blistering lesions are seen, it's a good idea to keep in mind herpes simplex 1 and 2, and the herpes zoster virus, herpes zoster varicella, all of these viruses causing blistering skin conditions. This hand, if this was the only presentation and needed investigation, could be investigated by using a sterile needle to debroof the blister, using a viral swab to make contact with the fresh base of the blister and sending that to pathology, and using PCR technology they can look for herpes virus. So this is herpes simplex, and very common in the population, there being an 85% seroconversion, and this may be transmitted even without clinical evidence of the disease. Transmitted by direct contact. Before getting something like cold sores, there may be a prodrome of itching and tingling, and both herpes simplex 1 and 2 is characterized by recurrent small blisters on an erythematous background that tend to recur in the same general region. The blisters form, there's 5 to 7 days of crusting, and then the area heals. Herpes also, besides affecting lips, can affect the genitalia, and the primary infection of herpes simplex is usually more severe than the recurrences. The virus persists in the sensory nerve ganglia, and recurrent infections or reactivations of the virus causing these outbreaks can be as a result of stress, illness, sunlight, menstruation, and from the dorsal nerve root ganglia, they travel peripherally in the sensory nerve fibres. There are 2 types of herpes simplex 1 and 2. Type 1 is usually the less causes less symptoms, but not always, and usually occurs on facial lesion on the face, while type 2 is usually sexually transmitted and usually causes genital lesions, has a longer primary infection and more frequent recurrences. But this is a general rule because herpes simplex viruses 1 and 2 both can affect the lips and both can affect the genitalia, and herpes simplex 1 may be just as bad, if not worse in some cases, than herpes simplex virus type 2. So treatment is basically symptomatic. If someone presents with recurrent cold sores on their mouth, then they can get Zovirax or acyclovir cream over the counter. When they get prodromal features such as tingling around the lips, they can apply the cream every 4 hours for 4 days, and this may decrease the severity and duration of the condition. With a primary infection, if it is severe, moderate or severe, then it can be treated with oral antiviral agents such as acyclovir, famciclovir, valciclovir for 5 days. If it is a recurrent problem, and usually these infections are recurrent, they do have recurrent activations, but if it's a mild recurrence, then no treatment may be necessary. If it's bothering the patient or moderate or severe in intensity, then antiviral agents may be used either when the activation occurs. The antiviral agent may be commenced for and continued for 5 days or so, or the patient may be put on an antiviral regime continuously for 6 to 12 to 18 months and then reassessed after that period, which is more of a suppressive type treatment. Also important to explain to these people that when they have active blisters and sores, that they indeed are contagious to others, though transmission of the infection may also occur when there are no clinical signs, and so this would be something that would need to be discussed with, say, a sexual partner, that activations will occur. The transmission of infection can occur when the blisters are present, but also when there are no blisters, though the transmission rate without blisters is a lot lower. Here we have another blistering condition. So we have vesicles, discrete vesicles on the back with an erythematous base, and here the giveaway is that it's in a dermal termal distribution, and of course this is Herpes Zoster. Here is Herpes Zoster affecting the upper branch or upper 2 branches of the left trigeminal nerve, and this is important because the eye may be affected, causing corneal ulceration, and so not only would someone like this require antiviral treatment, but they would also need ophthalmological referral to assess the eye and see if any topical treatment and debridement is required of the cornea. So as we've said, this is Herpes Zoster, otherwise known as shingles. You get the reactivation of the varicella virus in the dorsal root ganglia. Important to remember that the virus got there in the first place probably through chickenpox infection. You get the clusters of vesicles on an erythematous background, and they tend to occur along a single dermatome, although can sometimes affect more than one dermatome, but is almost always unilateral. Can be quite painful and hyperesthetic, meaning even a gentle touch can elicit pain, and may be associated with local lymphadenopathy or enlargement of the lymph nodes. Rarely, you may have systemic infection causing pneumonia and encephalitis. So, as we saw on the previous picture, beware of involvement of the ophthalmic branch of the trigeminal nerve, and it is contagious to those who have not been exposed or have not got an immunity to chickenpox. So basically, if someone has an outbreak of shingles, they need to be asked to keep away from anyone who may be immunosuppressed or at greater chance of developing a complication from an infection from this. And these people include pregnant ladies, newborn babies, elderly and frail, those with malignancy or being treated for malignancy, and those who are immunosuppressed either due to a disease like HIV or immunosuppressed due to medication. The treatment of herpes zoster, it's a self-limiting condition which resolves over a few weeks, and treatment is largely symptomatic. However, if someone does develop the rash and it's within 72 hours of the rash onset, it is preferable to commence them on an antiviral agent such as famciclovir, valacyclovir, or acyclovir. This will reduce the intensity and duration of the infection or reactivation and its symptoms, but also importantly, particularly in those over 50, it reduces the risk of post-herpetic neuralgia. Here we've also noted that analgesia is important if the lesions are painful. And as we've said, referral if an ophthalmic distribution is identified or if there are systemic features such as the pneumonia or encephalitis, which is fairly rare. Post-herpetic neuralgia is pain in the affected area which develops or continues after the rashes subsided. This is a difficult condition. It can last from weeks to months or longer, and the risk of it developing increases in age, so basically the duration and severity with increasing age are worse, particularly over 50-year-olds. Here we have a child who's presented with yellow crust with an erythematous base, and another child which it has progressed to involve larger areas of the face. These kids may have green mucus coming from the nostrils, and they've got generalised sores on the face with this yellow crust. And of course, this is impetigo, which is an infection, again, usually due to staph or strep. In contrast to cellulitis, this is a very superficial infection, and so you do not get cellulitis. As we mentioned, you get the oozing red plaques with yellow crust, found in the 0 to 4 age group, usually Staph aureus, and keep in mind that these things can trigger acute glomerulonephritis, even though that is uncommon once you keep that in mind in children. And it can occur on normal skin, or if there is an underlying skin condition such as eczema, then the infection may occur in that area where the skin barrier is broken down by the eczema, allowing the infection to develop and spread. And you can sometimes get large bullae or blisters full of pus, and this is called Bullus Impetigo. And it is contagious. So treatment, if it's very mild, saline or soapy water baths 3 times a day, and you can apply Bactroban topically, which is a topical antibiotic cream. If they're going to school, then the areas preferably should be covered with a Band-Aid. Generally, by the time we see the patient in clinical practice, they're requiring oral antibiotics such as dicloxacillin, flucloxacillin, or cefalexin or roxithromycin, particularly if they're hypersensitive to penicillin. Here we have a gentleman with a darker skin who has developed these pale hypopigmented macules, and there may be some slight scale. And in contrast, we have a pale-skinned individual with the same condition who has instead developed hyperpigmented or brownish discoloration as macules. This is pityriasis versicolor. Now, as we saw, you can develop red or tan macules on pale skin or pale macules on brown skin, and it may be slightly itchy. Often it's asymptomatic. And it's due to the overgrowth, not necessarily infection, but overgrowth of Malassezia yeast species in the stratum corneum. And what happens here is UV light reacts with carboxylic acids, which is released by the organism, and that affects melanogenesis. Under the microscope, you may have a spaghetti and meatball appearance, where you get mycelial form and yeast forms, and under the microscope this can be a typical finding. The treatment of pityriasis versicolor can be difficult. There's a number of different regimes available, and the difficulty is, I'll just go back a step. Here we go, the different regimes such as iconazole foaming lotion, Selsun shampoos, Canesten creams. Sometimes, rarely, you may need oral anti-yeast agents like ketoconazole, itraconazole. The difficulty here is that the rash can be quite recalcitrant, so you may start someone on, say, a Selsun shampoo regime, where for the first 2 to 3 weeks, every time they have a shower, they wash themselves with soap, they get the Selsun shampoo and apply it liberally over the skin, let it sit on the skin for a few minutes, and then lightly rinse off the Selsun shampoo and then pat dry. Do this every day for 2 to 3 weeks, and then they may be able to do it every second day for 2 to 3 weeks. And the treatment may need to go on for weeks. The patient can often judge how their skin is going, and they may restart the treatment if they notice that the rash is returning. The loss of pigment, the patient needs to be made aware that the loss of pigment patches will not improve with treatment straight away, because it will take time and sun exposure for the pigment to redevelop. This individual presented with this macular red area, and I'll take that back a bit, because the person usually does not present with this red macular area. What they'll present with is a widespread rash on their body, which is usually a salmon colour with some scale, and here on the back you can see it's in a fir tree or like a Christmas tree pattern. And when asking the patient, you might find that they've had this patch develop prior to this general rash, and it may still be present. It's not always present, but if you do find it, it is quite indicative, and this is pityriasis rosea. So we will point to that herald patch, which may be anywhere from 1 to 10 centimetres in diameter, occurs in about half the cases, but the main rash are small pink tan macules which develop over the following days following the herald patch. There may be some slight scale. They may have that Christmas tree pattern on the trunk. The face, arms, and are usually not affected, may be slightly itchy, and we think this is a viral infection which usually resolves of its own accord over the coming 8 to 10 weeks. Treatment is symptomatic. They may need antihistamines or topical steroids or cool baths if the itch is worrisome. The first slide we have here, we'll just skip over for a second, but here we have a person who has presented with a itchy, generalised red papular rash, and on the finger we can see something quite interesting, which is a fine red line, and possibly another one there and one there. So this, of course, is scabies. The scabies is caused by Sarcoptes scabii and affects usually school-aged children, some Aboriginal communities, and nursing homes. The adult mite is about 0.4 of a millimetre long and spread via intimate contact rather than by objects. And the mite will die in about a week in unworn clothing. Mites burrow through the skin, through the stratum corneum at about 2 millimetres per day, mainly in areas where there are few hair follicles. So the diagnosis is mainly clinical. The itch tends to be worse at night. Friends and family may also have a similar rash and also are itchy. The burrows are pathognomonic. So if you see these burrows, these red lines on the hands and wrists or finger webs, it's a fairly likely diagnosis of scabies. And the itchy red papules over the body are actually a secondary allergic reaction to the mite antigen, such as what the mites shed or feces or excrement. Treatment, again, straightforward, using some sort of permethrin-based application, such as Light Clear. This is applied to the skin from the jaw down, or including the face and scalp in children less than 2. It's left on for 8 to 24 hours and washed off. You can repeat this in 1 week to increase the success of the treatment. As for clothing, towels, bedding, this can be washed, ironed, heat dried, or even just stored for a week, during which time the mite will die. Itching may take a few weeks to resolve because the antigen causing this itch, causing this allergic reaction, needs to be absorbed. So that brings us to the end of our first lecture. There will be 2 more lectures on basic dermatology conditions. I hope you've learned something, and if you have a comment, please feel free to leave that comment down below. Thank you.